Okay, good morning. Thanks for coming. Hope everyone had a good weekend, one more weekend to do some skiing or something else in March here. But thanks to our exhibitors, B. Braun Interventional Systems and Novartis. I think at this point, I'll introduce my co-speaker, Dr. Erik Beckmann, who did his medical studies in Germany. He went to the Mainz Medical School for a 6-year degree. Then he did a master's in biotechnology, University of Pennsylvania. Then went back to Germany to Hanover Medical School, which is actually the birthplace of the elephant trunk and the frozen elephant trunk, and does more valve-sparing David procedures than anywhere else in the world. He then came back to the United States to Mass General, where he trained with 2 expert aorta surgeons who are known to us, Tor Sunt and Duke Cameron. He returned then to Hanover, where he developed a robust clinical and research practice in aortic disease and aortic surgery, and has published over 50 papers on aortic surgery. And we were fortunate enough to recruit him to join us here last summer. So this morning, what we thought we'd do was break down the recent aortic guidelines. These were published in November. Now, it's over 170 pages of information. We're going to focus today really on the ascending aorta and the aortic root. We're not going to talk about, but there's a lot of information in there on the descending aorta, the abdominal aorta, acute aortic syndromes. We're not going to cover those topics, but we'll focus on what we should be doing when we encounter a patient, which is not infrequent, with aortic enlargement. So I'm going to start by talking about some of the imaging methodology, surveillance. We'll talk about etiologies and in particular genetics and family screening. We'll talk about the medical treatment and the concept of the multidisciplinary aortic team, shared decision-making, and then Erik will take over and talk about what the surgeons can offer our patients. And then what gets kind of challenging is the surgical thresholds. Okay, so before we delve into it, does anyone have a sense what this eclectic group of people have in common? So they each suffered an aortic dissection, and there's some lessons to be learned here, I think. Most recently, this is the guitarist for Judas Priest. In the midst of a guitar solo, he recognized something was terribly wrong, finished the song, and then went to the tertiary care center, which was just 4 minutes away, and had life-saving aortic surgery for his dissection. Alan Thicke was playing hockey. I don't believe he was aware of his aortic aneurysm. Tragically, Jonathan Larson, the week before Rent came out, went to the emergency room 2 times with complaints of chest pain and was sent home both times with a diagnosis of gastroenteritis. Retrospectively, after he was found dead on his kitchen floor right before the opening of Rent, his family retrospectively realized that he actually had features of Marfan syndrome, as did Flo Hyman. And you can imagine she had a number of athletic physicals over the course of her profession, or her volleyball career, and she died in competition. Dr. DeBakey, who created the surgery that we're going to be talking about. And then many of you have heard me talk about John Ritter. Well, not only was he instructional in that his aorta was not recognized as enlarged on the heart scan that he had, but the fact that he had the aortic disease enabled his brother to get screened and have life-saving surgery. So first of all, as far as terminology, and it would be nice if we can all agree on this, because there's a lot of terms out there, ectasia, et cetera. But an aorta of 4 centimeters is considered to be dilated, and that's 2.5% of the population. An aorta of 4.5 centimeters meets the definition of an aneurysm, and that's 0.2% of the MESA database. You can see here how the risk of a aortic dissection increases once you get to 4 centimeters, and we'll talk more about that on the subsequent slides. So many of us that read imaging studies put the aortic size into the context of the nomograms for body size, age, gender. And so this is from Biaggi, which I think is still relevant. And so we grade the aortic size for both the sinus of Valsalva or aortic root as well as the ascending aorta. And obviously, if you have an 80-year-old man who has a 4 centimeter, 4.2 centimeter aorta, that has a totally different connotation than a young woman who may desire a pregnancy. When we make our measurements, and this information on this slide is not new in the guidelines, but the measurements should be made at reproducible anatomic landmarks that are perpendicular to the flow of blood. When possible, we try to avoid ionizing radiation. And the methodology for CT and MRI is you use inner to inner. Okay, so on this slide, this is new information. So patients with known disease, and when you're measuring the aortic root, the root diameter should be measured in the maximum sinus to sinus diameter, and multiple measurements should be reported. And our imaging group, John and Joao and others, are really good about putting these measurements into our reports, but you may see a change in the aortic diameter as these changes are implemented. Also, if it's reasonable to index the aortic size to the height or the body surface area, and I'll get more into that. When you measure it by echo, we do leading edge to leading edge, but they say you can use inner to inner if you wish. So this is what I'm talking about with the aortic root. You can see here a sinus to commissure measurement, and then a sinus to sinus measurement, which is going to be larger and can be actually significantly larger. I had a patient recently that was about 4 millimeters different between the two techniques. So the measurements are reported in the sinus valsalva or aortic root, as well as the ascending aorta. Great article that came out in JACC looking at discrepancies in the measurement of the aorta. And some of the reasons for the discrepancies include whether or not you measure in systole or in diastole, if you include the wall. This is a big one, especially for those of us that see CT scans and radiology. You get a PA measurement, and it's a very oblique measurement that increases the diameter of the aorta, and then the sinus differences that we just talked about. So I think many of us are familiar with this, and this is a little scary, right? So traditionally, our surgical threshold for the ascending aorta has been 5.5 centimeters. This is looking back at our IRED registry. 60% of the aortas at the time of the dissection are short of that 5.5 centimeter threshold. So obviously we need better techniques to be able to predict who's going to have a dissection. This is our own data from our excellent summer student, Daniel Johnson, now a medical student. And what we did is we looked at our aortic database and looked at the patients that had dissection and had imaging here prior. 94% of the patients did not meet that surgical threshold of 5.5 centimeters. But also importantly, in the studies that had been done within a year prior to the dissection, you can see the measurement here, and how the aorta size increased significantly at the time of the dissection. In my early years here, there was this perspective that if you had isolated or the majority of your aortic enlargement was at the root, that was a more benign situation. But in fact, that's really not the case. This is a nice paper from the Yale group showing these are the outcomes here and these curves here. But basically, they showed that aortic root dilation is probably more malignant. The curve is shifted to the left as far as aortic events compared to the enlargement in the ascending aorta. So when a patient wants to know what their risk is of having an aortic event, I think that this is really an excellent paper. This is from the Mass General group with Torsant and Erik, the first author of the guidelines. But this curve here gives you the risk of aortic dissection or rupture based on your aortic diameter.
So if you have an aorta of 4.5 centimeters, your risk is 0.4% in 5 years. So this is a nice chart to have if you want to have a conversation with the patient. What's the risk of surgery? What's your risk of having an aortic event? And the outcomes in this study are almost identical to those in the recently published JAMA Cardiology paper by Solomon looking at the Kaiser Permanente database in California. So that's a nice reference. In this study, bicuspid valve presence did not impact the rupture rate. So clearly from the data I've shown you, we need to do better as far as that size alone is probably not the ideal marker of who's going to have a dissection. And there's a couple other indices that are out there. There's the aortic height index. This is from the Yale group. And this is just from echo, looking at the aortic diameter by echo, looking at the body or the patient's height, calculating the ratio of 3.2 is a high risk. There's also a more simple measurement, the aortic size index using the BSA. Both, that marker of significance is 3.1. I'm going to propose that our echo lab adopt one of these. I think that the outcomes that they report in this article seem exaggerated compared to the other studies. So any of you that have ordered an imaging test here in our lab and have seen some of the reports come through with the aortic area to height ratio, that comes from these papers by Dr. Masri, who was a former colleague of Dr. Cavalcante. And basically what they do is they look at the aortic area and then the height and the ratio of those two. And if you have a ratio greater than 10 versus less than 10. And so what we have here on the left is the aortic root, and on the right is the ascending aorta. Green is the greater than 10. Blue is less than 10. And you can see here the outcome, and the outcome is all-cause death. It's not aortic events. So we just have to keep that in mind when we're interpreting this, that the outcomes are worse if you have an area to height greater than 10. So in the guidelines, they do make reference that if you are not of the normal body size, so in America, 5'4" to 5'5" for a woman, 5'9" to 5'10" for a man, if you're within one standard deviation, maybe these are less relevant, but there is probably a role for these. As far as surveillance, if you have a discovery of an aortic enlargement by CT, for example, you should get an echo. If you can't tell the size of the aorta by your echo, CT or MRI is reasonable. And then the big question is, how often do you repeat it? So we have our own unpublished data that the aortic growth rate in our population is 0.1 millimeter per year, 0.1. Now, there's obviously exceptions to that, but the guidelines come out and say it's reasonable to do your first image in 6 to 12 months. If you're following the patient for some period of time, you can space that out 6 to 24 months. Okay, switching gears now to the etiology. So this is where the guidelines get a little confusing, and I'm going to try to synthesize it as best as I can. But basically, they divide aneurysms into those that are genetic, and I'll get into those on the following slides, those that are bicuspid in etiology, and then if you have no family history and no syndrome, that's called a sporadic aneurysm, and Erik's going to refer to that term when we get to his part of the talk. So there's a big push in the guidelines to understand the genetics, and there's a strong genetic component to aortic root and ascending aortic aneurysms. About 20% of family members will, 20% of patients that have an aneurysm will have a family member that also has one. And of course, we want to be able to recognize Marfan syndrome and some of these other conditions. Marfan is probably the prototypical one that I think we're all aware of. But importantly, there's other non-syndromic familial conditions that lead to aortic dissection. Most obvious and most common is the bicuspid valve, but there's these other gene mutations that also cluster in families and lead to aortic diseases at relatively young ages. And I've seen a few of these recently. So just to put in a plug for the Marfan Foundation,
They have a great website, lots of really good information for patients and for providers, including this diagram, which is for patients, basically listing some of the physical features we may see with Marfan syndrome. And they have an outstanding annual conference for patients and providers. And the Ehlers-Danlos website is also excellent. Talks about the various criteria for diagnosis of Ehlers-Danlos, Lowy Dietz, characterized by bifid uvula, a very aggressive condition as well. So the guidelines recommend that when you see a patient with an aortic enlargement, that you think about and get a good family history. And if there's a family history of a thoracic aortic aneurysm, intracranial aneurysm, peripheral aneurysm, that's important. If the patient has features of Marfan, Lowy Dietz, vascular Ehlers-Danlos, these patients get genetic testing, as do patients that are discovered at a young age, or if there's sudden death in a family member at a young age. Often, you talk to the patient, there's a relative that died, and they said it's a heart attack. You delve into it, it may not be a heart attack, may be a aortic. If you do not have any of these features to lead you to genetic testing, then the family member should have imaging, such as an echo. If the genetic testing is positive, then the family can be tested for the gene. If the genetic testing is negative, then you have to do the imaging. And I think it's important when you can, and we've had this a couple times, where you can actually do the genetic testing on the relative you see a family member, their loved one died. If you can do genetic testing on the relative or the person that had the dissection, that's most useful. And I think it's important to whatever information we can get about the index case from the aortic size or other anatomy from surgery is very important. And this is a nice study from Jack from the past year looking at the different conditions and the way they present. So Marfan syndrome versus bicuspid and some of these other conditions. Red is aortic dissection, blue is elective surgery, purple or the dark color is death. So you can see Marfan syndrome, Lowy Dietz tend to have surgeries at a young age. Then they have their aortic dissections a little bit later. In contrast, bicuspid valves tend to have more elective surgeries, less dissections. And then these patients here with the non-syndromic thoracic aneurysms, they're not recognized as having anything. They have a lot of aortic dissections. And then even within these non-syndromic conditions, you can dwell down and predict the risk of a subsequent event. So just a few words on bicuspid valve, which I think we're all fairly familiar with, but about 50% of people will have aortic enlargement, depending on your definition of aortic enlargement. So important to be thinking of the aorta and making sure we understand the maximum diameter. And 20% of family members of patients with bicuspid valve will also have a bicuspid valve. So important that they get evaluated for their aorta as well as for bicuspid valve. This in the lower left is a patient of mine, was one of these people that grew rather rapidly, came off her blood pressure meds due to side effects, and over the course of a year, she developed rather significant enlargement of her aorta. And quite often, in a bicuspid valve, the enlargement is more distally, so we tell our sonographers to make sure they're imaging a little higher up the right peristernal to pick that up. But you can have enlargement at the aortic root as well. And this pattern of aortic enlargement is a focus of study. Joao tells me we're going to have MRI technology to look at the flow patterns in the ascending aorta and better understand this. But anyways, if you have a bicuspid valve, you have aortic enlargement, very important, whether you've had surgery or not, that the aorta is followed long term. Okay, as far as blood pressure management, we aim for a goal blood pressure less than 130 and 80, and you can shoot for 120 as well. Beta blockers are the drug of choice. The ARB is a reasonable adjunct. And of course, this is all based on data from Marfan. We don't have data in other etiologies
other etiologies of aortic enlargement, but this was the classic study in the New England Journal looking at atenolol versus losartan, a lower aortic root Z-score with atenolol, lower growth rate. But really the two drugs are both pretty good. This is a meta-analysis published last year in Lancet, but both beta blocker and ARB are good. And you certainly can use whatever you need to get the blood pressure down. I tend to avoid calcium channel blockers in Marfan, but you certainly can use that if you need it for blood pressure control. This is actually interesting from the guidelines as well. Retrospective data only on the use of statins, and there's a few retrospective series, this one from the Cleveland Clinic, where they looked at patients treated with a statin versus those not treated, and you can see smaller aortic diameter. So basically the recommendation is if you have evidence of atherosclerosis on a CT or whatever, you can use a statin as a two-way recommendation. If you don't have atherosclerosis, it's a 2B. Okay, other things. I didn't think smoking cessation deserved its own slide, but obviously that's very important for all of our patients. I also tell people to avoid fluoroquinolone antibiotics. There's not a lot of other things about lifestyle in the guidelines, but I do try to understand my patients' lifestyle and work issues. We do talk about weightlifting. Anything that requires severe isometric exercise should be avoided, burst activity, and collision sports. For those of you that want more information, this is a nice paper by the Yale group. And basically with weightlifting, you can have a rather significant increase in your blood pressure just with weightlifting. It is important, though, that our patients do reasonable exercise, that they do cardiac rehab after surgery, obviously. And it's also important, these patients are often quite anxious about their disease, or if they've had a dissection, it's important to get them connected to other resources they may need. And there's a lot of patient advocacy groups out there. Locally, we have the Rock from the Heart group, but like I said, the Marfan Foundation is a great resource. This is a really nice paper written for patients for activity recommendations for post-aortic dissection patients. Okay, multidisciplinary aortic team. So this is similar to what we have for both transplant and valve disease now, collaborative effort, and we know, and I'll show you, the inverse relationship of case volumes and mortality. And we know that this is really important in the acute situation, that patients that go to high volume aortic centers do better with their acute dissection, but that's also true in the elective situation. And so pertinent to this conversation today, when patients are referred for elective aortic intervention and they're maybe right at the borders, I think it makes sense to do that in the context of the multidisciplinary aortic team. And incidentally, we have just started having our aortic meeting. It's going to be the last Wednesday of the month right across the lobby here. And I'd encourage you to come and share your cases for discussion. We've had really great discussion the first couple meetings. So we've actually had a aortic team in place since about 2005. I think just a few of us remain from those early days, but we're real excited. Vinny deserves a big thanks for recruiting such a great group of talented and thoughtful cardiac surgeons who really a pleasure to work with everybody. But this is the data on aortic surgery volume and outcomes, showing as you get up in the number of cases you do a year, your outcome improves and your mortality decreases. And our volume, we understand, is 120 to 130 cases here at Abbott a year, and I think 30 at United. Also important, and I think this is my last concept, is shared decision-making. So if a patient and family have a particular preference, they're encouraged to share that. And this becomes, we've seen this in valve disease, athletic disease, but it's really important when there's somewhat clinical equipoise as far as borderline aortic sizes, what kind of surgery, which Erik is going to talk about, valve sparing versus a prosthetic valve, and TVARs for type B.
So that's what I have. I'm going to turn it over to Erik, and then maybe we do questions at the end.
Thank you, Kevin, for your introduction. Thank you for having me here today. Just as a quick reminder, my part of the topic of this talk will focus on two main sections. It's surgical outcomes and options. And my second part will be recommendations for intervention. So to start with surgical options and outcomes, I will spend some time on just introducing and explaining briefly the surgical options that we have, and then the outcome related to it. This slide is taken from the current guidelines, and basically the guidelines make a difference between 3 or 4 kinds of procedures. It's ascending aortic replacement, it's ascending aortic replacement with AVR, so surgical aortic valve replacement, and it's root replacement, either with a composite root graft or with valve-sparing surgery. And that seems very obvious at first, but I think it's very important to have a quick look at this table because the guidelines make a clear difference, like a clear comment what to fix under what circumstances. So for instance, if there's only an isolated ascending aortic aneurysm, we should only fix this. That sounds obvious, but especially when you go to conference or read papers, I mean, there's a lot of debate that some surgeons advocate for prophylactic extended repair. For instance, some groups who do ascending replacements often do also an hemi-arch, but actually the guidelines are against that and they clearly specify what to fix. So ascending aortic replacement is the most straightforward operation. Only patients with ascending aortic aneurysm should undergo this operation. It's a straightforward operation. The patient is put on bypass, the aorta is cross-clamped, the heart is arrested, and then the aorta is resected just at the level of the sinotubular junction. So the root, the coronary arteries, and the aortic valve are untouched, and the distal anastomosis will be done like 1 or 2 centimeters below the innominate artery. Cross-clamp time is quick, half an hour, 45 minutes. The entire operation is maybe 2-3 hours. So it's a very straightforward and safe operation. And I will talk about the outcomes in a bit. The next thing that the guidelines specify is aortic valve replacement in the setting of ascending aortic replacement. This refers to patients who have not only an ascending aortic aneurysm, but also valve disease. Basically, it's patients with bicuspid aortic valve stenosis or patients with aortic insufficiency. And the guidelines make a clear comment to do it in a separate approach, the supracoronary aortic replacement plus AVR. The last thing is aortic root replacement, and here we have 2 options. It's either conventional composite root replacement with a mechanical or a tissue valve, and there is valve-sparing aortic surgery, which preserves the native aortic valve. So this operation is a bit more complex and more challenging because we basically reset or we take out the coronary arteries and we perform a reimplantation of these, so that increases the surgical risk and is also technically more challenging. With composite root replacement, the operation is slightly easier because we just implant the valve. In contrast, valve-sparing aortic surgery gets a bit more complex. It's technically more challenging and demanding, and there's also risk for failure, either perioperative AI or AI in the long term that can develop. So it's only should only be performed at multidisciplinary aortic centers because it's technically more challenging and gives more room for problems. So coming back to this slide, the first 3 lines are basically just summarizing up what I just said, that in case of ascending aortic aneurysm, we should do the ascending replacement. With an aortic valve problem, we do it in 2 separate ways. And the last thing is about root replacement. But actually one important thing is here that they clearly say if the valve is salvageable and repairable, the patient should be transferred or should be managed at a multidisciplinary aortic center where valve-sparing surgery can be offered. I think that's an important thing to keep in mind. And since we are a multidisciplinary aortic center, I think we should also consider patients offering this option. Coming now to the outcomes, ascending aortic replacement is the most straightforward operation. I had a hard time finding a good study on that topic because actually people want to publish about fancy things, and ascending replacement has been around for 70 years and there are no good studies around. So this is some study from using the STS database. There are more than 20,000 patients there, so it's quite representative and it's a lot of patients. However, this study was published about 10 years ago, and the patients that are analyzed here underwent surgery from 2006 to 2010. So it's not quite representative for current data, but I think it's one of the best studies with large numbers and representative data. So the mortality in elective cases was 3% or 3.4%, and the stroke rate was 3.2% in elective patients. However, we have to keep in mind that 15% of these patients had redo surgery, which makes it more complicated, and about 30 to 40% had additional cardiac procedures, and we also know that this, of course, increases the risk. So I think what I tell patients in clinic when they have ascending aortic aneurysm, I think nowadays, if they just have isolated ascending aortic repair, the risk is maybe 1% or 1.5%. Of course, for a healthy patient, if the patient needs more concomitant procedures, the risk increases. But I think 1 or 2% might sound realistic. Outcome of aortic root replacement is the next big thing. There's actually a nice study also using the STS database. So it's only focusing on elective aortic root replacements in North America in adult patients, and it has almost 9,000 cases in it. This is basically the follow-up study from the previous one that I just showed, and this study also references and compares the data to the first one. I think it's a huge number and gives some good data. It has been published 3 years ago or 4 years ago, so it's quite up to date. And again, those patients underwent both valve-sparing aortic surgery and composite root replacement. Almost 2,000 cases with valve-sparing surgery and 7,000 patients with Bentall procedure. And also a lot of patients underwent additional cardiac procedures. Again, 20 to 30% had additional procedures, and the outcome was 2.2% mortality, and the stroke rate 1.4%. This number is slightly lower than the ascending replacement results in the previous study, but again, we have to keep in mind that the other data was older and not up to date. And also there's often some kind of bias that, like younger patients who are fitter often also get more surgery because they tolerate it better. So there's always some kind of selection bias linked to it. That slide is not about fighting, but kind of comparison, because mankind always wants to know what is better or what should we do. So there's often some debate on what should we offer, valve-sparing surgery or composite root replacement. And especially at conferences, there's often a big debate what we should offer. So I also want to spend a second on this. There are a couple of studies out that compare valve-sparing surgery to composite root replacement. And I always try to find something better, right? This is a big meta-analysis that was published quite recently, 4 years ago, by the London group. And basically, their key finding was that valve-sparing surgery showed fewer operative death and also fewer death in the long term. And the take-home message was that valve-sparing aortic root replacement should be considered as a first-line treatment option if the valve is repairable. So basically, this is also taken account in the guidelines. The guidelines say that valve-sparing surgery should be offered by multidisciplinary aortic teams. However, there's also, like always, as I said before, selection bias. And usually, if you have a closer look at these studies here that are listed in that tiny table, is that there's always, usually the valve-sparing patients are younger and have less comorbidities, maybe better LV function. So there's always some room for selection bias. And our center also published one of these studies that is listed here. I think they spelled my name wrong, but I get used to that. And I mean, I know that paper pretty well because we wrote it. And I think the mean age was 5 or 10 years younger in valve-sparing patients. They had less comorbidity. So there's always, I don't know, this meta-analysis cannot take account for that. But if you read the papers individually, I think you get the point. So although the guidelines say we should offer that, and I'm a big fan of valve-sparing surgery because I trained at a center that does large volume of these, I think there's nothing better or worse. It's always like there's one thing that is good for specific patients. And of course, if you have a 60-year-old or 50-year-old patient, he might benefit from valve-sparing surgery. And if you have an older patient, there's no really need to offer valve-sparing surgery. So that is my part for outcome and surgical options. Now I will spend some minutes on the recommendations for interventions. I showed this slide to my wife yesterday. She said, "Wow, that's super boring." But she's not a doctor, so she had lots of tables here. Wow! But when I talked to Kevin and we spent some time on preparing that talk, we also found that it's a pretty hard topic. And I don't know, it's just tables, and the guidelines have 180 pages of tables, and I mean, hopefully it's kind of interesting or at least useful. So as Kevin has pointed out, the guidelines always refer to the etiology, and I go quickly through it one by one. I will not spend a lot of time to Loeys-Dietz syndrome and other connective tissue diseases because we rarely see these patients. Even Marfan patients, we don't see that often in clinic. But I think these four etiologies are the most important ones to cover. So bicuspid aortic valve. This is the table referring to the recommendations for bicuspid aortic valve management or surgical management of patients. And I try to make it a bit more simple and take out or extract the key points of those tables. So I please ask you to draw your attention to that self-made table. So in every hospital in the States or in the world or wherever has a threshold or recommended threshold of 5.5 centimeters aortic diameter to perform surgery or to offer surgery for patients with bicuspid aortic valve disease and an aortic aneurysm. Multidisciplinary aortic teams can operate on patients at a level of 5 centimeters. There's a 2A recommendation if the patient has high risk factors, and there's a 2B recommendation for patients without high risk factors. So when a patient has some of those features listed in the table here at the bottom, table 14, then it's a it's a reasonable thing to offer it, and where these factors are not there, it's just considerable to offer surgery. So these factors are family history of aortic dissection, aortic growth rate greater 0.3 centimeters per year, aortic coarctation, and root phenotype of the aorta. Kevin mentioned that, so the guidelines actually acknowledge that a root phenotype or root enlargement is a bit worse for outcome or for prognosis than just ascending enlargement. Multidisciplinary aortic centers can also or should take account or should pay attention to the aortic area to height index. Our CT reports clearly mention that. They always give a nice number, and if it's greater than 10, surgery can be offered. And if patients with bicuspid aortic valve undergo aortic valve replacement anyway, the ascending aorta or the aortic root should be replaced at a level of 4.5 centimeters. The next thing that I want to talk about is Marfan syndrome. This is the table for patients with Marfan syndrome, and I tried again to make it a bit more easy to understand. So hospitals without a multidisciplinary aortic center should offer surgery at 5 centimeters aortic diameter, and centers or dedicated or specialized aortic centers should offer surgery at a level of 4.5 centimeters for patients with high-risk features. The table here lists the high-risk features, which is family history of aortic dissection, rapid growth rate, diffuse aortic root and ascending aortic dilatation, and marked vertebral arterial tortuosity. So these tables are always a bit different regarding or depending on the etiology to depend on. It can be a bit confusing to, find the right table in these big guidelines, but these high-risk features apply to Marfan syndrome. Again, the aortic area to height index should be considered, and the guidelines clearly say that valve-sparing surgery should be offered for Marfan patients in multidisciplinary aortic centers. The next thing is non-syndromic heritable heterotic aortic disease. These are patients that have some family members with aortic problems, but no identification of a genetic cause. This table is way easier to understand and way more straightforward. So it's 5 centimeters is the threshold for these patients, and dedicated centers can offer surgery at a level of 4.5 centimeters if high-risk features are present. And for patients with heritable aortic disease, that is family history of aortic dissection at a diameter less than 5 centimeters, family history of unexplained sudden death under the age of 50 years. I think that refers to one comment that Kevin made. I mean, some patients say, yeah, my father had a heart attack or just died. So if somebody says that and he has aortic root enlargement or ascending enlargement, it's pretty likely that it was not a heart attack, but some kind of aortic event. And the last high-risk feature is rapid aortic growth, 0.5 centimeters in 1 year or 0.3 centimeters in 2 years. The last group is sporadic aortic aneurysm. From my understanding, that's basically the big rest that doesn't have an identified cause, and these are quite a lot of patients in the end that we see in clinic and everyday life. Also, the table is way more complicated, but I think you can break it down to some things. So the diameter for surgery is 5.5 centimeters in patients with sporadic aortic aneurysm. In specialized dedicated centers, it's not 5 centimeters, but it's not 5.5 centimeters, but in specialized centers, it's 5 centimeters. In general, patients who are symptomatic should get surgery, although usually symptoms develop at a late stage when they compress the trachea or when chest pain starts. Usually we see a lot of patients with anxiety, and I don't know if really that is meant by symptomatic patients, but also like a lot of mental stress can be something that urges patients to ask for surgery. Growth is another thing that should be considered, 0.3 centimeters in 2 consecutive years or 0.5 centimeters in 1 year. And if patients undergo any kind of cardiac surgery, their ascending aorta or the aortic root should be fixed at a threshold of 5 centimeters. Again, multidisciplinary aortic teams can offer surgery at 5 centimeters, not 5.5 centimeters. These dedicated centers should take account of the aortic area to height index. And if patients undergo AVR, the ascending aorta or the root should be replaced if it is 4.5 centimeters or larger. And these two indexes are also mentioned here. That's the body surface area index to the patient, it's the aortic diameter index to the BSA, or the aortic diameter index to the patient's height. And these indexes should also be considered. I think that's it from my end. I think time-wise we are okay, and I think Kevin and I are very happy to answer any questions, and thank you very much for your attention.
Great talk. Really enjoyed it. I hate to say that we live sometimes by anecdotal experience, but the patient population that makes me particularly nervous are the ones that are the bicuspid aortic valves that, when you look at their echo, they clearly have effacement in the center-tubular ridge. Their ascending aorta is maybe 4.3. They're in the world of aortic disease, they tend to be on the younger side. So we go and we replace the aortic valve, and now they're 60 years old, and over the course of the next 10 years, their aorta gets enlarged. In 180 pages, I'm sure there's some data on why they picked 4.5 centimeters for replacing the ascending aorta, but those patients who clearly have an aortopathy with their bicuspid aortic valve, I wonder what your thoughts are as a surgeon in terms of just, replacing that ascending aorta because the risk is going to be there. I hate to say it's because you're in there, but it seems like because you're in there, to just do it.
That's a good question that I ask myself like 2 times per week if I have one of these patients. I think that it's coming to a gray zone where you make like individual decisions. I think if you have a young patient who's maybe 40 or 50 with bicuspid valve disease, you're a bit more aggressive to perform root replacement or ascending replacement, maybe even at 4.2, 4.3 centimeters. If you, in contrast, have an older patient with bicuspid valve disease, 70 or 80, of course, maybe you take it a bit easy. The tissue is more fragile. Patients have maybe more comorbidities. Then maybe it's safer to don't touch it. Usually in the OR, we also look at the tissue quality and the thickness of the aortic wall. That is not mentioned in the guidelines at all, but I think for surgeons it's a very important point. Sometimes we see patients with like just 4 centimeters dilatation, but the tissue is so thin that you know that it will just tear when you put some stitches in there. So you also in these patients be a bit more aggressive. I think if it's for me, and I think other surgeons do that too, if it's below 4, I think usually I leave it always in place. I mean, then it's just bad luck if it enlarges in the future. If it's 4.0 to 4.5, it's that gray zone that I just mentioned, and I think at 4.5 it's clearly, also according to the guidelines, it's a clear recommendation to replace it. If that answers or makes some sense.
It's a bit more complicated than that. So the reason is, I think one thing which, when you say sporadic, the one group which we haven't discussed here is post-aortic dilatation in tricuspid aortic stenosis. So post-aortic stenosis, you have some degree of post-aortic dilatation, and that may exist also in bicuspid. And the only way really to look at it now is when we surgeons do, historically or even today, we have done surgery, we have to unfortunately open the aorta. So we always weaken the aorta. That means there is a suture line there. But because of TAVR, now we are treating aortic stenosis without opening the aorta. So the only way we will know what is the degree contributed by aortic stenosis as a pathology is by following up these TAVR patients, whether they're bicuspid or tricuspid. So there is a very early study by a group in China, actually, which is 1-year follow-up of patients with bicuspid. Bicuspid disease is very common in Asia. So they have followed up systematically these bicuspid patients who have this dilatation around, say, 4 or something, and where we haven't touched the aorta because we have done the TAVR. And then what happens to the progression of this aortic dilatation? And we're running the same project here in terms of following up this bicuspid dilated aorta and see what happened. And I think that may give us the answer to the threshold which you are alluding to. Is in younger patients, should we actually intervene even the aorta sooner? Because, Tyrone David published many years ago that in bicuspid aortic valves, the aorta from collagen tissue, broadly saying, is weaker than that in the tricuspid aortic disease. So I think there are still some gray areas we need to understand in terms of how aggressively we want to pursue something. And the second complicated, sorry, it's a long-winded answer, but second complicated thing is a lot of young patients now want a bioprosthetic valve. So if we are doing a mechanical valve, it makes sense to me to do a root replacement ascending and deal with it once and for all. But if, say, a 60-year-old or a 55-year-old wants a tissue valve, probably leave the aorta behind because you are going to come back for something else later. I don't know the right answer, but I think we have to think, one by one, and probably we'll get there. But we need to study the aorta in a TAVR subset to understand what is the degree to which the stenosis contributes and what is the degree to which actually the aortic pathology as such contributes to dilation.
Thank you. That was a wonderful synthesis of a huge amount of information. It's very dependent upon numbers, and the numbers are very dependent upon people-related things that we don't recognize if you're in general practice. So if you order a scan and it's not gated, the sinuses are a disaster. Depending, it's quite variable. Also, the part of the cycle, you really want it diastole. So what I'd recommend is you've done a CT or an MRI that's not for this purpose, and you find it enlarged or an echo, that you make sure that you order it specifically for this kind of information. We design the outcome of the study so we give you the information. Otherwise, it's all over the place, and it becomes very difficult for the patients and you.
I'd like to ask a follow-up question to that, and I compliment both of you. That was really good. With regard to the size changes that you're talking about and the risks, what modality do you recommend to measure the size, and how solid is the data on? I mean, these are pretty small changes in size when you think about it, and the inter-observer variability in the measurements. To John's point, I'd just like to understand that a little better, because we've now got a lot of patients with aortas 4 centimeters and above, and so this becomes important.
So the growth rate that I referred to was on our echo database, but it's pretty and it was 0.1 for the trileaflet and 0.4 millimeters per year for the bicuspid. And that's fairly similar to some of the other literature that's out there, but the literature is kind of all over the place, and that's why we're doing the study. I think it depends. If you can see things by echo, I think echo is a fine way to go. I do a lot of MRIs, especially if you're looking at higher up the ascending, or you're not sure you're seeing the accurate root diameter. I mean, I'll intermix these, but quite often there's, like you said, there's a millimeter or even 2 millimeters difference between the techniques. But the key is for the most part, it's not going to make a difference as far as surgical threshold. And for most of my patients that I'm seeing, I'm following them every year for the most part.
Erik, could you comment on what the makeup is of the surgical volume here in terms of elective versus non-elective, and what particular surgery we're doing here? you
Yeah.
have that information.
Good question. We tried to find an answer before the talk. So we do about 20 to 30 dissections per year. That is pretty consistent. And these are the emergent cases. The total volume for aortic surgery is like 120 to 130 cases with a slight increase. We were not able to break it down to specific types of operations, so ascending, arch and stuff, but like the total number of aortic cases were like 130 cases per year.
And I would say that it's getting better also because most of these patients have a CT scan before. I think historically, historically, even today maybe in many centers, a lot of these patients, surgeon makes a decision on the table. And there are many times I have made the mistake of thinking, oh, this aorta doesn't look dilated. And the way I confirm it is I ask my anesthetist who's standing 3 feet away, do you think this is dilated? So I think we are doing more CT scans now. So we have a more objective measurement, I think. And I think that is contributing a lot to our decision making as well.
I agree. I think like especially patients with AVR maybe should get a CT scan. I mean, they get it usually anyway, but I mean, when I started residency, we didn't do any CT scans. It was that we didn't have the volume in the CT lab to run them. And I think especially cases with open aorta, they should get a CT scan. And another maybe comment to the imaging thing, I think one important thing is, or that I pay attention to, is that patients always get the same imaging modality. Sometimes when they come from outside hospitals, they come with a CT scan and the thickness is like or the increment is 3 millimeters, and you don't see anything on that. So I think it's either like MRI, echo, and CT scan, they give you different numbers. So I try to follow up my patients with the same imaging, and if there's some suggestion for change, I maybe, switch from echo to CT to confirm it, but I think that's one thing that I pay attention to. Maybe that makes some sense.
I just add, I think if you're looking at any one specific patient, a CT is probably your very best. It's best spatial resolution, you can gate it, and it's not subject to the window. So if in large groups of people, they may not be clear. In any one individual, that's probably your best.
I think that's a good thing. I mean, especially younger patients, I think it's good to follow with echo or MRI, and if there's a change, just get a CT scan for confirmation.
So I have a question actually. One of the guideline tables said that we should document the aortic diameter for dissections mainly on the table. So I'm a bit confused about it because when aorta is dissected, the diameter is actually false diameter because the false lumen is enlarged. So is it actually better that we document something more proximal or more distant, which can give us some sense? I'm not sure about the value actually at that point. And there are a lot of papers which say, I found the aorta dissected at 3.5, but I don't know what that surgeon means by that 3.5. Is it, what kind of diameter that would be?
Yeah, I don't recall that there's a lot of detail on that
Yeah.
part of the guidelines, but I think to me, what I kind of take away is, it's one thing if the family member dissected at 8 centimeters versus if they dissected, and you can get that information from your, every dissection has a CT for the most part. So I try to get that information. What else, did they find at the operation or was it a bicuspid valve? I try to, and I think the point of that part of the guidelines is learn as much as you can about the index case, and then you can apply it to the patient in front of you.
And Kevin, so in IRAD, which at least my experience now in this field is, I have seen most of the aortic dissections actually in tricuspid aortic valve rather than bicuspid. So what is the sense in the IRAD in terms of the relative percentage of these two pathologies?
Boy, it's a good question. I don't know the answer right off the top of my head, but I mean, bicuspid is quite common in society, right? With about 2% of the population. And I think probably bicuspids are probably underrepresented as far as an overall etiology. I mean, there's a lot of them because there's a lot of bicuspids out there. But I think the dissection doesn't occur quite as often as we think it would, and especially compared to some of these other conditions we alluded to.
I mean, I could also imagine that a lot of those patients get picked up early because of aortic stenosis that they develop at an early age, and then they get surgery. and then maybe also ascending or root replacement, then the problem is fixed, or they cannot have a dissection anymore. Maybe that also, I think you showed that one slide where they, with those graphs, they rather have elective surgery than dissection. So I think some of these patients just go and get picked up by their GP or cardiologist before something bad happens. And some patients with bicuspid disease, they come in their 20s or 30s or 40s, whereas all those Marfan patients, then they are not diagnosed and they suddenly come with a dissection. Maybe that's one point.
Yeah, but I mean, I know that's the sense in bicuspid, but I disagree with this, that bicuspid is present in 20s and 40s. In fact, with more TAVR now, we are seeing bicuspid in 80s. And there's a definite but subtle difference between type 0, type 1. And I'm pretty sure that in future we'll be separating these bicuspid pathologies, because type 0 may be a very different disease in terms of aorta, in terms of what you're saying, earlier presentation maybe. But type 1, especially, most of the time they tend to behave like tricuspid. But again, this is again not just anecdotal, it's just a sense, subconscious sense maybe, but I think we need to in future probably start separating these. I think we will agree that we may need to lower the threshold for aorta in type 0s maybe, for example, and things like that. We are going to learn a lot as we go forward. I think we should keep our local database as well. We'll learn more from that.
Well, and I think too, I think it was alluded to, is for the shared decision-making, once we have up-to-date, it would be nice to have our own data, right, on what is our mortality for valve-sparing aorta versus ascending aorta. And then you can share that with the patient and look at the curves of what is your risk of a dissection versus what's your risk of the operation.
Yeah.
Thank you for your time this morning. We do have a few online questions. I know we're at time, so maybe we can just do our best to get through all of these. Apologies if we do not get to all of them. The first one, it comes from Dr. David Lynn, and he asks, in clearly normotensive patients, is there a role for beta blockers or ARB?
I looked for that. I don't believe that it's in the guideline in that specific situation. So I showed the table where it's relevant, where it's the hypertensive patient. So I think in a Marfan patient, I would have a low threshold to try to get it on board. But if you see a patient, their blood pressure is 108, it's, I don't usually try.
Thank you. So let's go, Dr. Burke has a question, and he asks, if a patient has an enlarged ascending aorta, should we be recommending imaging for all first-degree relatives as a preventative measure?
So that's a good question, and I guess it comes down to how my personal style is. If it's a 70-year-old patient and they have a 4.1 centimeter aorta, I'd be less apt to do it than if it's a young patient with less than 50 with 4.5 centimeter aorta, which I think really has other connotations.
Yeah, absolutely. So the last question again is from Dr. David Lynn, who asks, for the echo lab, do you recommend inner to inner or leading edge to leading edge? And then he goes on to say the latter does yield significantly larger number.
So the standard and confirmed by these guidelines is leading edge. Now, that's always been the standard, and some of the size thresholds were determined using data, using leading edge. It may be more accurate if you did inner edge and compared that to the tomographic imaging, but jury's out, I'd say.
Thank you. That's all we had for online questions. Is there anything else in person here?
Can I have John a question? So in surgery or even in the normal route, we find that the non-coronary sinus is usually the one which is more large, relatively speaking. So could there be just a measurement where we take that measurement from LCC, NCC, or left and right coronary commissure to the non-coronary? Do you think that is?
It's certainly available. The scans have already been performed. You could do that. It's just a matter of doing it.
Right.
And it's very identifiable.
We should probably look at that.
There was a nice study looking at that last year, Vinny, in the Journal of the American Society of Echo, where the aortic enlargement was perpendicular to the opening angle. And I think that's what you're
Yeah.
saying, yeah.